Hello, everyone. I know it's been a while, and we hopefully have some new names and faces joining us this evening. But I'm Alexis Davis. I'm the social media manager here at RSDSA. I'm joined by Jim Broach, Executive Vice President and Director of RSDSA, and Dr. Francesca Beaudoin, who I will be briefly introducing this evening. We are so excited to have you all back after our summer break. We have a lot of amazing Facebook Lives and even a virtual conference coming up this fall. So we are so excited to be seeing you all again and engaging with you all as we continue to talk about CRPS. So today's guest is Dr. Beaudoin. She's joining us this evening to discuss emergency room care for chronic pain patients and those with CRPS. She is an associate professor and interim chair of the Department of Epidemiology and an associate professor of emergency medicine and health services, policy and practice. Dr. Beaudoin is a board certified practicing emergency physician and is the principal investigator of multiple federal and private grant awards. She has written and implemented practice management policies for healthcare systems on pain management and opioid prescribing. And I know we're going to learn so much more about her during tonight's presentation. Now, always remember that the information shared here tonight is helpful, but please remember to consult your physician for personalized medical advice. And now, all right, before I turn it over to Jim, please remember that this live is also being recorded. So you will be able to, of course, rewatch it later. And we will also add it to our YouTube channel as well. We always encourage you to save or bookmark our previous and future lives so you can easily access them later at doctor's appointments, when you're in the ER, if you want to send them to friends and family, etc. Now, enough over here, talking over here. Jim, anything, any announcements for you?
I just want to give a pitch. Today was our longest day of golf, and our golfer, Tony, he probably did over 100 holes. It was a beautiful God day. It was beautiful on the course today. And I just want to encourage people, if they wanted to make a gift, to go to our website. It could be just $1, $5. Every dollar is well invested in helping our community. And I'm really excited to be back. And emergency room department is a tremendous interest of me. And I'm so excited that we're having our doctor talk today about emergency medicine.
Definitely. So don't forget to leave your questions in the chat and we will go through those questions at the end of the presentation. But all right, the floor is yours, Dr. Beaudoin.
Thank you so much, Alexis. Jim, thank you for having me this evening, and thank you to everyone who's joining virtually. So I'm going to talk tonight about navigating the emergency room for patients with chronic pain. I left this a little broad. I know that obviously we're here with RSDSA, and many of you, or you may have family or friends who are suffering from CRPS, but I think this is applicable to lots of chronic pain conditions. And so I'm going to leave it a little broad, and then we can get into some specific scenarios and questions later, I hope. A few disclosures. I do have some research funding from the Centers for Disease Control and the National Institutes of Health, as well as the Arnold Ventures Foundation. This supports work investigating pain management, best practices for pain management, and also responsible opioid prescribing. And I am also a senior medical advisor for the Institute for Clinical and Economic Review. So I'm going to start off with a quote from our own Jim Broach, and this came a couple of weeks ago as we were discussing doing this talk tonight. Too often the ER is a minefield for patients with chronic pain. And I think this probably rings true for many of you listening in. And we should do something about this. This should not be everybody's gut reaction to the emergency room. I think when we think about the ER, there are a lot of hurdles and barriers that we encounter. And some of these things have to do with stigma of having a chronic pain condition. The pain itself, people are uncomfortable. It's hard to be there, maybe physically uncomfortable. There may be an emotional aspect of it. There's a new relationship forming. You're probably meeting someone that you've never met before, and you're trusting your care, your health with them. And they're meeting you for the first time as well. And they may not know your medical history. And it's a period of rapid learning, but that can sometimes present a barrier to effective care in the ER. And so communication is really important. And then, as we know, the emergency room can be really busy. A lot of what I'm going to talk about tonight, should have a big old asterisk next to it. In the era of COVID, the ERs are busier than they have been, and there are a lot of new challenges. I'm not going to focus too much on that, but know that everything that I'm saying is dynamic in the face of the pandemic, and hopefully we'll get back to a state of normal. But I intend to leave you with some lessons that you can take with you now and in the future. So I think this is probably what the ER feels like when most people come to the emergency room. Very few people want to be in the ER, and it probably feels a little bit in the dark and left difficulty navigating the visit and what's going on. But your doctors and nurses and others that are taking care of you want the ER to feel like this. We want the ER to be a place where people feel welcome and that they can receive exceptional and timely care. And I think, I feel this way, and I know that my colleagues do as well. I do know that sometimes what patients may be thinking might not always be what doctors may be thinking. And I'm going to leave you with some quotes. This came from the last time I worked in the ER. I took care of a few patients with chronic pain, and some of the things that they said to me, and these are things I've heard many times. I don't want to be here. I just want to feel better. I want this pain to go away. And also sometimes I know it's worked before. And these are sentiments that many people convey when they're in the emergency room. And sometimes there appears to be a disconnect with the provider that's seeing them. And I'm hoping I can give you all a little bit. It might be what's going on inside your doctor's brain to kind of deconstruct some of those barriers. So one of the first things that a provider that's seeing you in the ER might be thinking, is this an emergency that needs immediate medical or surgical intervention? So somebody may be coming there because they have an exacerbation of an underlying condition, an underlying chronic pain condition, maybe CRPS. But the provider that's meeting you for the first time might have a hard time knowing if severe leg pain is a flare of underlying chronic pain or represents a new condition like a life-threatening or limb-threatening blood clot. And so this is something that's really important to us to try and distinguish if this is a flare of chronic pain or is this a new problem. And so ways that we can determine this are figuring out what we call the history of present illness. So really trying to drill down on the current symptoms and how those compare to past symptoms, doing a thorough physical exam, seeing how people respond to various treatments, and it may involve some diagnostic tests. And this is sometimes where a disconnect can happen because people might, be very convinced that one thing is going on, but your doctor may still want to do tests. And I think all of this is forming a partnership and trying to get at what's going on today's visit and then providing the best care for today's visit. And so that gets it, like, what are the best treatments for my patient? No one size fits all. No two people are the same. And we're still learning a lot in this area. And I personally still think we have a long way to go in the way that we manage pain. We still treat as first line non-steroidal anti-inflammatories, Tylenol, so NSAIDs, non-steroidal anti-inflammatories. These are things like ibuprofen, naproxen, many things that people probably already would have tried at home. And we often still do these in the emergency room as well, because they're safe and they're generally effective for a broad range of painful conditions. Not all pain conditions. And in fact, with CRPS, NSAIDs have been shown not to be as effective compared to some other treatments. It would not be surprising to me if your doctors in the emergency room still wanted to try this. And again, they're pretty safe and well tolerated unless you've had an allergic reaction to these things. And so it may be worth trying, but acknowledging that they might not work and other therapies might be needed. And we'll talk in a little bit about what are some things that you can do to help your doctor navigate this. Opioids may be right for some people. Part of the work that I do has to do with the harms of opioids and taking care of patients who have developed an opioid use disorder or addiction to opioids, pain medications, or otherwise. But opioids are still a good treatment for pain for some people who have moderate to severe pain and are a good treatment for some acute pain conditions. And so opioids may be part of emergency room treatment for a presentation that's related to severe pain. There's a lot of caution around opioid prescribing right now. And so if anybody's visited the emergency room, you might have felt some friction around pain management and opioid prescribing. And that's because of this overlying opioid epidemic. And so I personally think that opioids are right for some people and in certain scenarios. And that everything we do in medicine has to be balanced risk and benefit. And so this should be a conversation with your doctor. We do know that there are other potential treatments for chronic pain, flares of chronic pain, and specifically CRPS. Ketamine is one that we know can be effective. Ketamine is gaining increasing acceptance in emergency rooms, and I have been engaged in research looking at the effectiveness of ketamine for acute pain in the ERs, and we know that it's feasible, that we can do it, that patients have improved pain outcomes, and that it does reduce opioid use. It's hard to study ketamine in certain conditions like CRPS because it's pretty rare, and the likelihood of patients coming into the emergency room with flares of CRPS are low because it is still a rare condition, but we do know that ketamine is effective. And so I think that is a potential treatment option in the emergency room for a variety of painful conditions. Steroids and gabapentin are other potential therapies that work. And there are other treatments that are still being investigated. And we need to do work as researchers and scientists. We need to figure out what the best treatment is for the right condition, and not treating all pain as if it's the same. If you're a hammer, the whole world can't be a nail. And I think that's how we've treated opioids, NSAIDs, and Tylenol for a long time, and been on this merry-go-round of doing the same therapies. Another thing your doctor may be thinking is, does my patient need to be admitted to the hospital for pain? And so these are things that are going through our heads. Like, is there an emergent condition versus is this a flare of a chronic condition? And when I say, is this an emergent condition, it's not to discredit that pain itself is not urgent. I am distinguishing that from something that might need an acute medical or surgical intervention. Medical meaning timely antibiotics, or surgical. Is this something that needs surgery within the next 12 to 24 hours to treat, to avoid a bad outcome? And again, so it's not to say that pain is not urgent, but it's urgent in a different way that other conditions are. So we're thinking about that, the urgency of other conditions, balancing that with the appropriate treatment, and then trying to figure out, does somebody need to come into the hospital for pain management? Because sometimes that needs to happen. And we appreciate that most people don't want to stay in the hospital, but sometimes that's needed for pain control. And so things that I'm thinking about when I'm deciding if someone is okay to discharge versus needing admission is the response to treatments that have been we've tried in the emergency room. And so failure to respond to treatments is making me think, does someone need an inpatient or observational overnight admission for pain management? Functional goals. So these are things that you can talk about with your doctor kind of early in the course of, like, what is the goal of that ER visit? And these, for me and for patients I take care of, are often things like, I want you to be able to go home and walk and get to the bathroom okay. And I want you to be able to go home and sleep tonight. And so the goal may not be a 0 pain level, but it may be the kind of reasonable functional goals that you can go about your day-to-day life and do what you need to do without being disabled by pain. We should be able to control pain with oral medications. That's kind of a criteria for me for sending patients home. And that this kind of last thing, that we've ruled out other serious conditions. This is an important one. And so I've given you some insights into things that your emergency room doctors, nurses, and other providers might be thinking. And here's some things. These are 5 things that you can do right now. So if you were to have to go to the emergency room, hopefully not, but if you were to have to go to the emergency room tomorrow, these are 5 things that you could potentially do or work on. First one might take slightly a little bit more planning, but developing a pain plan with your physician. And this is, when I say your physician, I'm talking about the person that may manage your chronic pain condition. If you don't have a pain plan in place, I urge you to make an appointment with the doctor that manages your pain long-term, or your primary care provider, to work out a plan for acute unscheduled care. And so this can be acute unscheduled care, can be a trip to the emergency room, a visit to an urgent care, or also a sick visit to your primary care doctor. And a plan will have actions to do in place at home, things to try at home. And these could be pharmacologic, meaning prescription or non-prescription drug therapies, non-pharmacologic treatments like ice or heat or meditation, mindfulness, other things that might help avoid the emergency room in the first place. And these really need to be customized to the individual and the type of chronic pain condition that someone is dealing with on a long-term basis. If you have a pain plan written out, it's an objective reference for your treating provider. I feel like so many times I've heard from patients that I have engaged with and taken care of, they've said to me, well, last time I was here, I told the doctor what worked for me and they didn't listen. And it's tough. And that's, that ends up sometimes being a point of conflict. Whereas if you have a pain plan in place, it really takes it off of the patient, off of the family member. And it's an objective plan that you've drafted and worked on with the person that knows you the best. And you can bring that into the emergency room with you and share that with the provider who is taking care of you in the ER. And it's really helpful then if that provider has a contact number, recognizing that it may be somebody else that's on call, but somebody that we can close the loop with. And then it's really taking it off of you and there's a plan in place. And then it makes it easy to follow. And it also is customized to what works for you as an individual, because again, no two people are the same. I think pain plans should include, again, both pharmacologic and non-pharmacologic treatments, so drug and non-drug treatments. And again, something that you've worked out with your provider, your primary care physician, the person that knows you best. And again, including these recommendations for both home and emergency care. And it's also helpful if there's thresholds for when, criteria for discharge and admission, but that's a really comprehensive plan. And it may take time to sketch something out that's thorough and works, but I feel like this is a key to success for people in navigating the emergency room. Number 2, bring someone with you. Again, and this is another COVID asterisk because visiting policies have varied over the pandemic, but I think it's really helpful to have a friend or family member with you if you're in a lot of pain. Sometimes if you're in a lot of pain, it can be hard to remember instructions. It can be hard to remember the history of what just happened and to ask the questions that you want to be able to ask. If you have somebody with you, a companion, they can help provide history for you, and they can also be a distraction during potentially long wait times. And it's also helpful to have an advocate. I really think it is important to bring somebody with you to the emergency room if at all possible. And again, if allowed, given limitations during the pandemic. Number 3, prepare for long waits. I hate saying this, but this is a fact of most emergency department visits these days. And so if you know this heading in, I think it can make it a little bit more bearable. When I've had friends or family have to go to the emergency room, I have kind of given this the same thing. It's going to be a long time, but if you know that, you can prepare for that when you go. And again, just because long wait times are the norm and that you may wait, it doesn't mean that we don't think your pain is urgent. And it doesn't mean that we don't want to treat your pain. So sitting and waiting may just mean that there are other things that are immediate emergencies that need intervention. And these are things like heart attacks or gunshot wounds. And I think we can all kind of conceptualize this, but knowing that that's often what's going on in the background, and that when a person comes to the emergency room, you get what's called being triaged based on conditions, vital signs. These are like blood pressure, heart rate, and again, whether or not something needs to be acted on immediately. And often if you're there with a flare of chronic pain, you might not receive that same level of triage. And I shouldn't say you might not, it's unlikely that you'll receive that same level of triage that somebody is that's having a heart attack. And I think we can all understand and appreciate that. But so just putting that in context, bring something to help you relax or distract you that can pass the time. I think that's very useful. We all have electronic devices, charge them, bring a charger. This sounds silly. I wish that I had when I work, I sometimes bring chargers with me because people's devices die all the time. It really helps pass the time. Bring headphones, a charger, bring your electronic device. And if possible, take your home pain medications before you go. Often I hear that people don't want to do that because they want to demonstrate that they're in pain. We believe you're in pain. Like, just tell us what's going on. Let us take care of you. And it's okay to take your pain medications at home. You don't have to hold out just to make sure that you're in severe pain when you get there. In fact, that can perpetuate the pain cycle. So if you're scheduled to take some pain medications at home, it's okay to take them before you leave. Provide important details about symptoms. I just wanted to give you a list of kind of the things that the checklist that we're going through in our head when somebody comes in with not just pain, but any condition. And pain is the most common reason that people visit the emergency department, just the causes of the pain vary. The history is really important. If visiting for a flare of chronic pain, again, we're kind of drilling down on, we want to know what's the same and what's different. You know your body better than anybody else. Like, tell us how this is different, or is it the same? Is this the same as other flares of pain? That's very helpful to us. Location, timing, severity, all of these things are important. Most of us are probably familiar with this pain rating scale. We've all probably been asked it at some point in our life. On a scale of 0 to 10, where 0 is no pain and 10 is the worst pain imaginable, tell us what number your pain is. This is helpful to us because it also lets us know response to treatment. You don't have to say your pain is a 12 to convey that your pain is really severe. To me, an 8 is really bad. A 7 is really bad. Those are all, that's severe pain. So moderate pain is 4 to 6. And severe pain is 7 to 10, and mild pain is kind of that 1 to 3. And so thinking about, like, you know, the worst, 10 really is the worst pain imaginable, and you might be at a 10. But using that scale is helpful to us, because then when we come back and ask you those same questions and how you responded to treatment, we can kind of calibrate things and whether or not it made an impact. And then knowing what therapies you tried at home, again, any medications that you may have taken, but also non-medication treatment is helpful to us, because then we're not reinventing the wheel and we know what you've tried and we can know where to go from. And then lastly, ask questions. This is really important. You should feel empowered to ask questions. Some key questions I think that are good to ask your doctor are, what should I expect during today's visit? You know, asking this at the outset. Before leaving, what should I do for pain when I get home? Understanding if you're going home with any new prescriptions or any changes to the way that you take existing prescriptions or other non-medication treatments. Knowing when you should follow up with your doctor. Should you see them the next day? Are you heading into a weekend? Is it important to see them before the weekend? Should you see them within a week? Do you need a specialist visit? And then what are things I should look out for when I'm at home? And that's important, because sometimes things evolve over time. And are there any key things that should prompt you to return to the emergency room or call your doctor? I think this first question is a really good one. What should I expect during today's visit? Because sometimes the ER is busy and it's chaotic, and you don't know what's going on in the room next to you or 3 doors down. And so this lets you, asking this question may give you some insight into your doctor's plan for your visit, in case that it wasn't communicated effectively. Never feel bad asking questions. I mean, this is how we understand, and they've done studies that demonstrate that often people don't understand their discharge instructions. They don't know what's happening during the visit. And so asking, if there at any point something doesn't make sense, it's totally, ask your doctor, ask your nurse. And this is totally reasonable. If you're in too much pain, have the person that you brought with you ask these questions as your advocate. So I'm going to stop here. Thank you so much. I really appreciate the opportunity to be here tonight, and I hope this was helpful. And I'm going to stop sharing my screen now, and hopefully I'll have the opportunity to answer a few questions. Thank you.
All righty. Thank you for that. We definitely have a good number of questions already in the chat. So I'm going to go through some of the questions that have been asked so far. So one question that we've seen a couple times already, what type of CRPS education does ER staff receive? And I guess kind of a follow-up, are physicians aware of the McGill pain scale, whether that, I guess just be in general or, specifically emergency room physicians?
Yeah, those are great questions. So I think because CRPS is pretty rare, even though, I have received education about that during medical school. And I know actually one of the professional societies I belong to, the American College of Emergency Physicians, has done education around CRPS and other chronic pain conditions, you need to refresh that over time, because I can still count on one hand. And so I've been in practice now 15 years, and I can count on one hand the amount of patients that I've seen come in with flares of CRPS, because it's rare. And so some people are going to see, have taken care of more patients than others. But I think when you're dealing with any rare conditions, it's important to have kind of those like booster trainings. And so this is where I think the advocacy and work that your organization is doing is really important, and also kind of puts burden on me and my colleagues to make sure that we're doing a good job educating each other and keeping best practices, kind of at the front of medicine. And but those are great questions, and education and ongoing education is really important.
Alexis, just a second. It's so important. Education is so important, but what's the right portal for us if we're having a problem with an emergency department, or even one of my retired board members had problems with Johns Hopkins, the whole system, they're contractors, and they really don't care. So how do we approach that?
Yeah, I think so. Probably this needs a multi-pronged approach. There's kind of what's going on at the individual level. And I think that's where if this is something with an individual patient, a primary care physician or pain physician really needs to be a strong advocate and acting on, that person's behalf, and also on behalf, getting involved in the system. And so it really takes, I think, having someone that wants to be a champion for the idea. And finding someone within that healthcare system that wants to champion this issue. On a bigger level, I think there's some opportunity potentially, as I was mentioning, the American College of Emergency Physicians, I think there's some opportunity for some education and advocacy at one of our conferences coming up. And there are a couple of professional society meetings where it would be possible to do, some didactics, and that is going to reach a wide swath of providers. And so something like that might be an interesting venue, but it's not, again, that's like the macro level. And then there's what's going on with the individual person. And certainly a big conference presentation does not help someone in the moment when they need to go to the ER with pain. And that really, I think, is where having your doctor, be your advocate and getting on the phone with the provider in the emergency room or the inpatient service and figuring out the best kind of care plan. And it's tough. I 100% acknowledge it's a challenge, but we need to do better, and it has to happen on multiple levels.
Thank you.
Definitely. So this next question, we did get a lot via email. And then of course, we've had a few people also ask during the live so far. So how does one get hospital approval to do a ketamine infusion in the ER? And what criteria, enables ketamine infusion in the ER?
So ketamine is a topic that's near and dear to my heart. I did one of the first randomized control trials of ketamine in the emergency department. And this is something that we've seen change a lot over the last 15 years. When I first started practicing, we never used ketamine in the emergency room for pain. We only used it for general anesthesia or sedation. But then we started to learn that ketamine had some interesting properties that in low doses, it made a good pain medicine. And we now, in many emergency departments, ketamine is much more common. I think that the experience is probably going to be very varied depending where you are. And, I know that in my hospital systems where I practice, we have a protocol for low dose. We call it low dose or sub-anesthetic, meaning much less than the dose of ketamine that would be needed for general anesthesia to put you to sleep. And really little doses, it's a good pain medicine. And so our hospital has a protocol in place and guidelines for low dose ketamine for pain management. And I helped craft those policies, but our hospital is not the only one that has them. You can prescribe ketamine and you can administer ketamine in low doses without guidelines or policies. However, Ketamine got a bad rap as a general anesthetic many years ago because people, when they came out of general anesthesia, had emergence reactions, which were these kind of agitated behavioral reactions to coming out of ketamine. And so for a long time, people got really gun shy about using ketamine because they had a very negative experience with it. And I think it's taken a lot to overcome that. And then there's also the side of ketamine that's a drug of abuse and a club drug. And for all those things, it's made ketamine hard to adopt into practice. But slowly over time, I've seen a shift in accessibility to ketamine. And I think this is where it does take having a champion in the healthcare system. And so, your personal physician or pain physician perhaps can be that person. I think you'll find, again, more widespread acceptance of ketamine and ketamine, both in a bolus injection and infusions in academic medical centers, I think is going to be more likely than smaller hospitals. But it depends. You may, I don't know, if you went to an emergency room and said, I have instructions from my personal, my pain physician to get a dose or an infusion of ketamine when I'm in a flare of pain, you might get someone to do it. Because there is growing literature around the safety and effectiveness of ketamine for pain. I do understand that it's still variable, and we have some work to do here. And this is kind of advocacy at the national level, and where this organization and other organizations can be helpful in setting forth kind of best practices. But ketamine, I think, is a really viable and useful treatment for lots of painful conditions, in particular flares of CRPS. And I've used it myself with success in the emergency department.
Jim, do you have any questions? I know I have a good number over here, but of course I wanted to ask you.
I'm fine.
Okay. Well, actually, there was a quick follow-up question for that one about ketamine. I'm sure this, may also vary depending on where someone is, but will insurance cover ketamine infusions in the ER?
So I have not personally had any problems with insurance covering ketamine infusions. I've administered ketamine many, many times. We've not had any issues. I never like to give a blanket all or none statement, but again, in my experience, have not had insurance issues. Ketamine is also generic, and it's a pretty cheap medication. So this is not like we're using some new, fancy immunomodulatory drug that costs thousands and thousands of dollars. Ketamine's pretty inexpensive. And typically when things are done on an emergency basis, they don't have the same pre-authorization requirements that treatments do when you do them on an outpatient basis.
Okay, I also received a question from John earlier that I thought was pretty interesting. Whenever you had a list of the different types of treatments that those with chronic pain will receive in the ER, he asked about nerve blocks. Now, is that something that would occur in the ER? Is that something that you would actually have to be admitted to the hospital, not through the ER, to actually, receive?
Great question. So nerve blocks could potentially be part of the management. Depending on the location of the pain and the condition, emergency physicians are trained to administer nerve blocks, usually using an ultrasound machine to help locate the nerve, and then administering a local anesthetic. And similar, for those who don't know what a nerve block is, you probably are familiar with it at the dentist and getting, Novocaine as a local anesthetic in your mouth, and that's a nerve block. And so when we're talking about doing nerve blocks for other types of pain, it's finding the nerve that supplies or provides sensation to that part of the body, and doing a similar thing to Novocaine at the dentist. And we do it for, a lot of times we're doing nerve blocks in the setting of trauma for broken bones, things like that, but we do them for other painful conditions. Migraine is a common one that's been growing in popularity, doing occipital nerve blocks for migraine. I don't know that for CRPS, you might find somebody who might be willing to try it, if particularly if there's a history of that working before. And But I think that peripheral nerve blocks and CRPS probably still need some evidence behind them. And so, everything that we do, we try and be grounded in good research. And so I'm not aware of an emergency department based study for that, that scenario. And again, with the caveat, it's really hard to study acute pain and CRPS because it's not common. And so to mobilize and carry out a big study like that is hard. And so we're lacking the evidence that we need.
Definitely. We have a question from another Jim who's on Facebook who mentions, he said, peer review publications show about 74.4% of CRPS patients are at a serious risk of suicide. And that's something that we are all familiar with. Is the ER equipped to manage overwhelming pain as an intervention in situations like this? I know the ER is equipped for multiple different things, but how, when that comes into play, how does the ER handle that?
So the emergency room is, the interface, that's where we see people in crisis. And so we're used to dealing with people who are in crisis, potentially because of severe pain, suicidality, in the same way that we treat, suicidality is a crisis. That's a mental health crisis. And that's a life-threatening crisis in the same way that someone having a heart attack or a stroke is. It just is, there's not the same type of tests that we can do. It doesn't show up on an EKG, but it still is a crisis. And so we receive training in detecting and responding to people who may be having suicidal thoughts or behaviors. And we recognize that uncontrolled pain is a risk factor for that, and is a risk factor for mental health and deteriorating mental health. And so your doctor taking care of you in the emergency room should be in tune to that. And if you are feeling that you are at a place where, with worsening depression, anxiety, or having thoughts of wanting to harm yourself, that reaching out to your provider, but also the emergency room is a place to go if that's what's going on. And again, I recognize that it's not the place that people want to go, but it is the place to get help for both severe pain and suicidality.
All right, we have another question from Bill that I thought was really good. How does one receive higher doses of pain meds when having been on pain meds for decades, or maybe even a shorter period of time, and the normal doses are not doing the job, without seeming like, a pain seeker, because it's like they really need it? How do they go about getting that and being taken seriously?
Yeah, this is, I think, a big challenge for a lot of people with chronic pain, particularly if people are on chronic opioid therapy, even people that are on chronic opioid, people that are on chronic opioids under the direction of their doctor. And I would refer back to having a pain plan carved out with your provider. So if you have a pain plan worked out with your provider that you are maybe on, somebody who's been on oxycodone 3 times a day for years, or maybe takes a long-acting opioid pain medication, you may need higher doses of opioids if you come in with acute pain, or alternatives like ketamine. But getting away from ketamine at the moment, say that part of the pain management and opioids, I think that, again, taking it off of you as the person and just saying, because I've heard this from patients like so many times that, and I think that, as a patient, to say, like, I know that the only thing that works for me is 2 milligrams of hydromorphone, 2 milligrams of Dilaudid. And the doctor's saying, well, they just want the hydromorphone, they just want the Dilaudid. But I think taking it off of you, and if that is a pain management plan that you've worked out with your doctor as part of your like acute unscheduled care, then it makes it easier and it's more objective and easier to follow. And so I think working that out as much as you can ahead of time makes it a little less of a volatile, unpredictable situation when it occurs. Because again, it's like a plan for unscheduled care. You're not planning on it. It's not scheduled. So as much as you can map it out in advance, it makes it easier. I'll give an analogy, and I hope this isn't a bad analogy, but we all, like, at some point, somebody's probably asked us to think about like advanced directives, like end of life care, end of life wishes. And we do that in advance because in the moment, like, it's really hard to sort it out. So like, and not that that like end of life is like a flare of chronic pain, but it's the same concept in that like you're working out, like in the event that something unplanned and unpredictable happens, you've already mapped out like what the course of action is going to be. And it takes a lot of the heat off of the moment, and it takes like some of the stigma off and things like that. And then just having an honest conversation, I think trying to like build rapport with your doctor and talk about potential alternatives. And I would say the last thing is being willing to try, being willing to try what your doctor wants you to try. If they want to try giving a dose of Toradol or some steroids, and maybe it will be the time that it works. I think those things have like little harm, and so it's worth trying. And then trying to get some, consensus and buy-in that you're both like agreeing on the plan. Like that relationship has to be a partnership, and it's got to be both ways. And so hopefully that's some helpful information. But I think the pain plan, again, I'll go back to and emphasize that I think that's really helpful in working it out with the person that again knows you the best.
Have you ever used nitrous oxide in the emergency department?
I have, but not for, I have not used it for acute painful flares of chronic conditions. I've used it mostly for painful procedures, like short temporary procedures. And I know we chatted about, Jim, that it sounds like there's a clinical trial underway. And I think it's an interesting therapy. And this is the type of things that we need to be doing, because we need more tools in our belt to manage pain. We need to do a better job at managing pain. And the more that we can do things that are targeted to the specific condition, and the more that we have at our disposal, the better it is for everybody, right? It's easier for me to treat pain. And if I go to the ER with pain, then I'm going to have a better experience.
So here at RSDSA, we have an advocacy committee, and we're always, coming up with new ways to help spread the word, of course, about CRPS, and to make sure that CRPS wards are advocates. So I know we just had a question from Laura, who asked, I know it's different because of, the pandemic, but how do CRPS wards, chronic pain patients, go about making their spouse a patient advocate?
That's a really good question. So I think, bringing, can be your spouse, a friend or other family member, somebody that you trust. I think engaging them with, primary care visits or visits to the pain physician are helpful. Giving that person some, reading to do, give them homework, learning about the condition. And, there, so much of pain is subjective, right? And I know that I am talking to an audience that understands this more than anybody else. But I think as much as you can remove the subjectivity and understand kind of what's going on with the underlying condition, learn about it, engage that person in the visits, have them come to things like this and listen and learn, look on the website, and really, I think that's when somebody crosses from just being like a supporter to an advocate, when they really understand and understand the condition. And I do think that, and I intentionally put the word advocate on one of those slides, because I do think that that's different than having support. An advocate is someone that is going to ask the hard questions when you don't. If they feel that you need something, they're going to speak up. And I think that that's okay. I think we all need advocates in medicine. Healthcare is a challenging environment to navigate. And I felt that as a physician, I felt that healthcare is challenging to navigate. And that's, and that's coming from the medical community. And so having an advocate is really important. You should never feel bad about that. If somebody has an issue with an advocate being present, that's not the patient's problem, right? And so advocacy is, I think, really important and key. And, we're not talking about getting emotional or hot-headed. We're just talking about somebody that's not in pain, being able to ask the right questions and pay attention. Taking notes is okay. All of those things are really important.
Thank you.
Definitely. We have a question from another ER physician who's actually asking about secure texting. He's asking, do you think electronic communication systems like secure texting can help reduce anxiety among CRPS patients in the ER?
Secure texting with the emergency department providers or staff, or with the primary care physician, or are you talking about the physician communication?
I will clarify. I
Yeah.
just have that part, but we'll see. I know there's like a slight delay in the stream.
So I will say that, like, in general, I think that digital health and tech solutions are solving some of our problems. I know that I can actually secure chat. That's what it's called with our platform. I can secure chat other doctors while I'm working. And sometimes they respond more quickly than they would if I paged, I'm dating myself, pagers, if I page them or called the answering service. And so I do think things like that. I know that for me, I have the secure chat platform on my phone. And if someone messages me, it pops up on my phone and I can respond. And so I do think when you increase communication between providers, especially, sometimes what happens in the emergency department is a black box to the outpatient provider. So anytime that we can streamline communication, that's, and we shouldn't rely on the patient just to be the conduit of information, right? So if we have better communication between the emergency department, the hospital, and the outpatient team, it's a better and more seamless experience for the patient. And so tech is part of the answer to that. And I've noticed changes, when I started practicing medicine, everything was pen and paper, everything. Orders were pen and paper, notes were pen and paper. And, there's like a nice quick part about that, but then I think it's better, this electronic documentation and communication is better for the patient experience in terms of getting everybody on the same page.
Definitely. And to go back to the question before that, I saw Jenny is in the Facebook comments and she just said, my partner calls himself my care provider up front and helps them see him as my go-to. And I definitely think that is important as well. It's like, of course, partner, spouse, whatever title was like, hey, I'm here to make sure this person gets the care that they need. I think that is, really big, really important.
Great. I like that phrase.
Definitely. I like that phrase as well. Thanks, Jenny. Thanks for sharing that. Now, I know we have a couple minutes left, and I know I've gone through most of the questions in the chat, but this was like the big question that I definitely wanted to say for, kind of near the end, especially if we had some folks that kind of joined us late. So we already know, and Jim, help me out a little bit if you can kind of catch what I'm asking. So we already know that, unfortunately, a lot of CRPS warriors are not going to the emergency room because they feel like people do not understand what's going on. They feel like the staff, just doesn't understand CRPS. But there are often, other times where they have to go to the ER for other issues. Maybe they're having heart issues, maybe kidney stones, maybe they sprained an ankle, something along those lines. So I guess to kind of summarize, everything that you've discussed is like, what is the best way to receive comprehensive care for a syndrome like CRPS, especially one that can occur at any time in the emergency room setting?
That's the $1 million question.
The $1 million I wanted to ask.
I mean, I think to summarize, a lot of the things that we talked about, but, coming to the emergency department, and maybe when you come to the ER, knowing that we're there to help. We all went into this line of work because we want to take care of patients, and we're not just there to do this stuff that you see on TV shows. We're there to take care of everybody. We take care of the very tiniest babies to people in their hundreds and everybody in between. And we take care of things that are, urgent, and we take care of, gunshot wounds, and pain is the most common thing that we take care of in the emergency room. That is the number one reason why patients go to the emergency room. And I know that there is a lot of stigma attached to chronic pain, and that many of you may have experienced that, but try not to bring that with you when you come to the emergency department. and let us take care of you, and let us take care of you by, and I'll repeat for those that are just joining, some of the things that we talked about earlier, like giving really good history, letting us know what's different about the reason that you're there today, or maybe the same. Letting us know what you've tried at home, what you haven't, what's worked and hasn't worked. Bringing someone with you that can be an advocate for you. Having a physician that you've worked with before coming to the ER to carve out a pain plan, and having that person available if we have questions and we need to talk to them. And we want people to leave the emergency room feeling like they got good care, and that the reason that they came from the emergency room, that we helped, and some of that is hard when you're in pain, but we have treatments available. And so I think that we can get there, and just, so having, I guess, a little faith. And I realize that not everybody's going to have a positive experience, but I hope, and I think that the way we treat pain is getting better, but we still have work to do. So thank you for that question. And I hope that some of tonight was helpful. And, I appreciate the audience this evening. And so thank you, Jim and Alexis, for everything that you all are doing. Really important work.
I want to thank you for all your research and clinical expertise. I mean, it's been wonderful. I was just so amazed on all the research you've done all these years. It's immense, and it's great.
Definitely. And so before we wrap up, I definitely wanted to remind everyone, and I did pin this in the chat on Facebook. So if you are watching later on YouTube, I will also make sure that this is in the description. We have a couple of different items that you can actually take with you to the emergency room, or you could just carry with you in your car, and your partner's car, keep with family members. But we have emergency department and urgent care guidelines. Those are on our website. Those have been linked in the chat. We also have our I have CRPS cards that you can print out. Those are linked in the chat. And we also have laminated cards that you can keep in your wallet that explain what CRPS is. Those are unfortunately sold out in the store right now, but we are working to get those back because we always have so many people who are trying to purchase those. They are $2 in the RSDSA store. And like I said, those are laminated, so you can keep them in your wallet. But all of those resources have been linked in the chat here on Facebook, and I will add them to the YouTube description. So definitely keep those items with you because they are handy if you are going to urgent care, the ER, your regular physician, any of that. But definitely I want to thank you once. Oh, yes, Jim.
Wonderful. We do have a ketamine protocol for managing neuropathic pain flares that's written by a Canadian emergency room doctor. So that's on our website, and we could make that available too.
Definitely we'll have that available. So once again, Dr. Beaudoin, thank you again for all this great information. As always, if you didn't hear in the beginning, we will have this video pinned to the top of our Facebook timeline for easy access if you want to rewatch it, and we will also add it to YouTube. We will also, continue to share additional resources that we are getting from other physicians, just any tips that we can always share with you all. And I did see a few people in the chat also ask about a physician in their area. If you are in need of a physician in your area because you really need to come up with, a pain plan whenever you're going to the ER, please send us a message here on Facebook, and we will work to get you a list of physicians in your state so that you can get the help that you need. So like I just said, if you have any questions for us, if you need a support group, if you're looking for a new physician, or if you want to tell your story on our blog, please send us an email at info@rsds.org. Thanks again, and have a great evening, everyone.
Thank you.